Okay, dear friends, welcome once again to this edition of the course on periodontal and cardiovascular diseases. Thank you very much for being with us. Thanks again to the Spanish Society of Periodontology and, of course, to the Dentate for their sponsorship of this initiative, which is very important for the patients and the dental teams. Of course, special thanks to the speakers of the 3 webinars that make up the course. They are great experts in the field, which they are transmitting to us in a very practical way. In this third session, we will deal with a different concept about the relationship between periodontal and cardiovascular diseases. So, in the first part, Dr. Gómez Doblas will explain to us why the arteries get sick through the process of atherosclerosis. Juan Gómez Doblas is a doctor of medicine, a specialist in cardiology. He works at the Virgen de la Victoria University Hospital in Malaga, Spain, and obviously he is an excellent person. As a cardiologist, he has a big heart. So, Juanjo, please, when you want.
Thank you, Dr. Cazor. Thank you, Miguel, and thank you for the SEPA for have the opportunity to speak with you today. Well, my task today. Second. Let's see that they can put my presentation. Do you see my presentation now? Miguel, can you see my presentation?
Now.
Thanks to the opportunity of stay here to SEPA and Dentite. I need to talk today about why the artery is damaged, the process of atherosclerosis and its consequence. Well, the atherosclerosis is not new concept. We know from a long time, from some 2 centuries ago, that the atherosclerosis is a process that affect our arteries, and this is this disease how can produce different cardiovascular disease, especially heart attack, MI, stroke, etc. The first probably I would like to comment is the definition of arteriosclerosis or atherosclerosis. Normally, the difference is the atherosclerosis is the progressive sclerosis classification and of the arteries, of the wall of the arteries, and normally when this happens with the deposition of the lipids that we call atherosclerosis, and this is probably the concept. That this is a normal process probably in relation with age, but that we know and we comment after, probably we have different risk cardiovascular factors that increase the possibility that we develop this disease. We can discuss that probably how our style of life in our countries probably is the cause of this big problem. The normal structure of the blood vessels is with arteries or veins have 3 primary layers. The petecia is in the out on the surface of the wall of the artery of the vein. We have the media is the muscle in the medium of the wall of the artery, and we have the intima. This intima normally is that we have the endothelial cells and the specific function, very so important to the regulation of the integrity of this wall artery, and how it have very important in the how is the outcome of the atherosclerosis in our arteries. Normally, these 3 structures characteristic of both vein and arteries, but normally in the arteries we know that they have more bigger walls, and the veins, the media is more thinner, it's less developed in this kind of vein. No? But the problem is this: Yeah? Normally we have one artery with the normal structure in the wall, but the problem is we are with the time we develop this plaque. This structure is the atheroma plaque, and then the problem is it could be that this increase progressively with the time, but in some occasion we have a rupture of this plaque, and in the same moment we start the thrombus, and this thrombus probably can have occlusion of the artery in the coronary arteries, in the carotid, or in the peripheral arteries in our legs, and then give us the problem that we know as cardiovascular disease. This is very important because the cardiovascular mortality in Spain, but in all of the development in our countries is maintained, probably is decreased a little in the last decade, in the last year, probably in relation that we have a best prevention and best treatment to treat the acute problem in relation with the arteriosclerosis. How this happen? Well, normally if we have in the process of arteriosclerosis start here. Yeah? The pathogenesis of arteriosclerosis start when the monocytes migrate into the intima, and then these monocytes have a transformation in the Schwann cells, and this process is very important to the LDL cholesterol. In this slide, in this graphic, we can see exactly how is the mechanism that how we produce this fatty streak and we produce the atheroma plaques. Normally, the monocyte have in one endothelial cells that have this function. This monocyte have passed through this the intima, and then in this process they change from monocyte to macroph. They engulf the LDL cholesterol, and they have a transformation in the Schwann cells. The Schwann cell, the accumulation of these Schwann cells is going to produce the fatty streak, and this is probably, as we see is increase progressively the plaque. In this process, it's important to the inflammatory markers, like cytokines, or the proliferation of the smooth muscle cells that the two again can transform in Schwann cells and increase the plaque of atheroma. This is here. We can see here the fatty streak. That is the first thing of arteriosclerosis that we can see without magnification, and that these fatty streaks contain the Schwann cells in the arterial wall, below the endothelium. The problem is that not only this plaque that could be increased progressively or slowly, but the problem is when they produce this disruption and then produce the acute thrombus inside the coronary arteries. And probably the most important for us, from the point of view of the prevention, is that here in the right, we don't do we can do the prevention, because in this moment we fail at the prevention. Probably in the place that we need to call to the action is in this moment, in the first moment, and that we have the endothelial dysfunction in this process of the atherogenesis. In some occasions, the patient or another colleague don't understand well why in some occasions we have patients so stable and then patients with the acute syndrome, acute coronary syndrome, for example. And this is I try to explain this with this graphic, because in the one normal artery like this, the endothelium is without problems. This happens in some occasion is this progressive situation is increasing slowly, years to years, and then the plaques are increasing. In this moment, in some occasion, this plaque is stable, but they have a thin fibrous cap, that's the see that we have here, with containing a large lipid pool. But the problem is they have many inflammatory cells inside. In this situation, probably we can recognize this patient that for example, in the cardiologist patient that they have only stable angina, that when they perform exercise, they can feel pain in the chest, but always with the same level of exercise. We are talking about one stable situation, and normally it's in this moment. But the problem is, in some occasion, in these plaques could be vulnerable and this is because in some occasion in relation with another desencadening factor as smoke, exercise, stress, could be that this vulnerable plaque disrupt the plaque, and in this moment start the thrombus, and this is a phenomenon that starts suddenly, and then in this moment is when the patient have a heart attack or stroke. It's important to recognize too that in some occasions this could be happen not only in big plaques or in big occlusion of the artery. This could be happening with the little plaques, but if these plaques are vulnerable because they have a thin fibrous cap or they have a lot of inflammation, could be desencadening this acute syndrome. And then for this, the prevention probably is the best option at this point, because you can have acute problem, severe problem like MI, acute myocardial infarction, not only with the big occlusion, because we can have to with the mild occlusion. And this is the concept that we need to understand in the point of view of the prevention. The mechanism of the plaque rupture is in relation in two ways is very important. One is the inflammation that we are going to talk again posteriorly, but the two is in relation with the coagulation, the situation that in some occasion we have patients that have a high level of prothrombotic situation, and then in this patient is when we can have the problem. This happens especially in the patient with the increased cardiovascular that we commented before. And I would like to comment too that the inflammation is very important in one point in the development of the atherosclerosis, but the two in the disencadening of the problem of the stable atherogenesis, stable atherosclerosis, and different situations that produce chronic inflammation, that the chronic infection, and for example, periodontitis that we are talking about now, or the patient with the respiratory problems, inflammatory intestinal, or patient, for example, with the inflammatory disease, rheumatoid arthritis, for example, are patients that have more risk to the development, not only atherogenesis, but to the disencadening of the rupture of this plaque in some occasion. This is very important to know, because we need to probably treat this in order to prevent the development of the atherosclerosis. Because the problem is when this happens, this inflammation is probably a threat. We think that it's a molecular problem, but the consequence is myocardial ischemia, thrombotic diathesis, or vascular dysfunction. In all these situations, the inflammation is important and is relevant. What is the consequence of atherosclerosis? That is probably all know this. What is this consequence? The most common for us is the angina, heart attack, the stroke is very important especially in women, and the arrhythmias or peripheral arteriopathy. And then this is all the consequences in all the vascular situation. We can have problem in relation with the atherosclerosis. And this atherosclerosis is that we commented before in relation with the presence of the presence of the different risk cardiovascular factor. Some risk factors are probably we can change, because this, for example, the gender, the male we have more risk, or when they have a history of coronary artery disease in our family, probably it's difficult to control this risk cardiovascular factor. But we have another risk factor that we can control, we can prevent in order to prevent atherosclerosis. For example, obesity, diabetes, smoke, hypertension, dyslipidemia, no exercise. All these situations is possible to modify when we change our health style of life. And this is very important because this slide from Spain, but it's important to know that when we have different situations in relation with the cardiovascular mortality, and normally this difference is in relation with the different prevalence of the different risk cardiovascular factors. For example, the south of Spain, we have more cardiovascular mortality in relation that we have more diabetes and more obesity. And the paradox of the Mediterranean area, we know that we have low prevalence of coronary artery disease. Probably for the one possibility is the genetic in this population, but the second probably is the style of life of the Mediterranean country, with the Mediterranean diet, more exercise, and less obesity in some situations. But this is important to maintain this style of life. That is true is that we have in the arteries we have a continuum cardiovascular. This means that perhaps we can have normal arteries without occlusion, but if we have endothelial dysfunction in these arteries, this is the first step in this long way that at the end we have is occlusion of the artery or subocclusion of this artery, and these are going to have event, as we commented before, could be go to the mortality or the disability of our patient. For this is very important, probably, that I am going to comment, is that if we can prevent in this first step of the atherosclerosis, probably we can prevent this situation. And probably the point of view of the cost efficiency or cost effectivity is the best option that we have. Probably for this is important that in the most of the population, after some age, probably 40 years or 30 years old, it's necessary to evaluate the risk of cardiovascular disease of the population. And this is very easy to do with a scale like this, like the score scale. And instead you use another, but it's so similar that this scales are based in epidemiologic studies, and with something so easy like to ask the patient if the patient is smoker or not, of the age, blood pressure, gender, and cholesterol, we can say to the patient how is the risk of this patient in the next years. And with this tool, we can probably do an excellent prevention in this patient in order to try that he reduce the risk, the modifiable risk factor like smoke, hypertension, or cholesterol. And for this, important to remember this concept that when we do secondary prevention is because we fail into the prevent. Normally, is that we perform now, and this is at this moment the patient have event, and probably the prevention is good, but probably is better if we try to do primary prevention. This primary prevention is when the patient have risk cardiovascular factor. We treat this risk factor, and then we can prevent the event. But probably the most important for me is the concept of primordial prevention. Primordial prevention is when we try to do prevention before we have risk cardiovascular factor. And this is the moment that we need to do the best of us in order to prevent. I mean, especially this is important in the children's. And I would like to comment in this way. This paper is the paper that was in Lancet 2 or 3 years ago, and this is a study, very elegant study that one population in South America and Bolivia, and this population normally are not sedentary. They take only vegetables and little animals, and these patients, they perform, and this population, the investigator performed a scan of the coronary arteries, and they found that they don't have arteriosclerosis. Population that they 40 years or more. If you see the graphic of the less, normally the people with less arteriosclerosis that we know before, it was the Japanese woman, but in the Simane woman, this level of arteriosclerosis is less. This population normally is working all the day, and then working, and they don't have obesity. It's true that they have more mortality for infection, but in relation with arteriosclerosis, this means that probably the arteriosclerosis is a problem in relation with our activity and our diet in our style of life. I would like to finish always with this slide, and this is because probably you don't know this. This is a TB seria for the Mexican TB, as from 10 or 15 years ago. But we can see here, this is the class of this school. This is the teacher, and this is the boys and girls of this classroom. And you can see here that he have some girls and boys that they have overweight. And it's important, I like to comment this because when recently these people, 20 years after or 15 years after, they have a new meeting between them. And we can see that the most of these people, the children are overweight, continually overweight when they are adult. And then this is probably important to know that we need to treat in this moment, because in this moment we have risk cardiovascular factor, sure, and only we can prevent the next is the event, the acute event, the severe event like angina or stroke. In the moment we can prevent this. And probably my last thinking, or probably my last conclusion, is that all the people that we treat population, we have the opportunity to give always the same message, is that we need to have a very good health lifestyle, because if we can do this, probably we can prevent the cardiovascular disease. Thank you so much.
Okay, thank you very much, Dr. Gómez Doblas, for your brilliant presentation on how the process of atherosclerosis develops, which is so important in the pathogenesis of cardiovascular disease. Thank you very much.
Okay.
And in the second part, Dr. Eduardo Montero will talk to us about the relationship between periodontitis and atherosclerosis. If we can consider periodontitis as one more risk factor for cardiovascular diseases, which is a very important thing. Eduardo Montero has a degree in dentistry, a master's degree in dental science, a master's degree in periodontics, both from the Complutense University of Madrid, and he holds the European Board in Periodontics from the European Federation of Periodontology. Thank you very much, Dr. Montero, and it's your turn. Thank you.
Thank you very much, Miguel, Professor Carasol. Thank you very much for your kind invitation to participate in this course. I think that this is a very important task, and I will share my screen. Just a second. Okay, so I assume that you are able to see my screen. Just a sec. Okay, so as Dr. Miguel Carasol was, excuse me, okay. Just a second, I will try to put this message of sharing the screen this low at the bottom of my screen. Okay, so as Professor Carasol was introducing, my task is to talk about the relationship between periodontitis and atherosclerosis, and if we could consider periodontitis as a novel risk factor for the development of cardiovascular disease, for the development of cardiovascular events. Of course, I'm going to talk about almost anything about cardiovascular diseases, because I will be crazy after Dr. Gómez Doblas and his excellent presentation. But just to take a small view to what we are talking about, I think that it's very important to introduce both diseases in terms of epidemiology. And if we look at cardiovascular diseases, we need to know that particularly in developed countries, in the first world, these are the leading cause of mortality. And nowadays, according to the World Health Organization, they suppose more or less 30% of the deaths in the first world. For example, if we take a look at the data that we have for the pandemic of COVID-19, nowadays we know that approximately 1 million people in the world have died because of this disease. And every year, in the case of cardiovascular diseases, the amount of people that die for this reason is approximately 18 million. So imagine the importance of these diseases in humankind nowadays. Is indeed first cause of death since age 60, and at 40 years old male have when a man is 40 years old, the probability to suffer a coronary event is approximately 50% from his lifetime from that moment. So, as I said, very, very important disease in terms of epidemiology. And the lesion that is the origin of cardiovascular diseases has been very well described by Dr. Gómez Doblas, the atherosclerosis, and at the end are coronary heart disease or stroke, the main consequences, the ones that we are more aware of, and the ones that have a higher risk for to take patients to death. And if we take a look at the epidemiology of periodontal diseases and of oral diseases in general, and in trying to put this in perspective, it's very important to understand that oral diseases are the most prevalent in the world, the most prevalent diseases affecting human beings. Caries, particularly on permanent teeth, is the most prevalent condition worldwide. But if we take a look at periodontitis, it affects more than 50% of the adult population. And if we particularly take a look at severe periodontitis, it affects approximately between 10 and 13% of the population and is the sixth more prevalent disease of humankind. For those ones that are maybe curious between caries as the first or the most prevalent disease and periodontitis as the sixth, there are two types of skin infections, either by fungus or by bacteria, and two types of headaches. But apart from these conditions, we can say that oral diseases are the most prevalent diseases in the world. And particularly, we have data from Spain in the past. We didn't have them, but thanks to particularly to Dr. Carasol and one study that was published in 2016 in a work that was done together with the people from Ibermutuamur, and in which more than 5,000 subjects were included, all of them representative of the Spanish employed population. We observed that approximately 8% of the working population in Spain, which means approximately 1.5 million people, suffers from severe periodontitis. So again, a very extremely high prevalent disease. And indeed, this is one of the similarities that are shared by periodontal diseases and cardiovascular disease. As we have said, both are really high prevalent conditions. As we will see later on, they share a lot of risk factors, common risk factors. So it will make a lot of sense, and it will follow the guidelines presented by the World Health Organization to do some kind of common risk factor approach in order to prevent both type of diseases. They both present an incidence peak approximately around 40 years old, so in what we can say or name young adults. They have an important impact on quality life of our patients, and their treatment presents or it correlates with a high treatment costs, either for the patients or either for the public health systems. And what is more important, both diseases are potentially preventable because the main risk factors for these conditions are modifiable. So moving a little bit into what we call periodontal medicine. Periodontal medicine is that part of periodontology that is focused on the study of the link between periodontitis and several systemic diseases. And this is indeed not new. Indeed, it was at the end of the 19th century, particularly in 1891, when P.D. Miller for the first time talked about the mouth as a focus of infection and the possibility that microorganisms or their products could enter in the body and exert harmful effects at distance. And indeed, this was just the first step, because nowadays we know that periodontitis has been linked with up to 54 systemic diseases. Of course, the body of evidence for all of them is not the same. And in this slide, what I try to show you is that those ones that have a strong body of evidence for the association between periodontitis and these conditions are first diabetes, which is what I would call the start of periodontal medicine, second cardiovascular diseases, and third what we call adverse pregnancy outcomes, which is mostly preterm birth or low weight at birth. So, which are indeed particularly related, as you can imagine. So these are the three systemic diseases or conditions that are mostly related with periodontitis. And throughout the rest of my lecture, we will try to answer to these three questions. First, is there a causal relationship or is the association purely accidental between periodontitis and cardiovascular diseases? Is the association true, let's say, or is it because they share common risk factors between them? And last, and probably more importantly, Is there something that we can do? Can periodontitis or its treatment influence on the pathogenesis of cardiovascular disease and vice versa? And we will try, to answer to these questions. And starting from the first one, we need to understand, Dr. Gómez Doblas already introduced the most important risk factors for cardiovascular disease, the known as traditional risk factors or Framingham risk factors, because they were deeply studied in the series of papers of research projects carried out in that town. And the most important ones are smoking, diabetes, obesity, cholesterol, sedentary lifestyle, all these conditions that are related with cardiovascular disease. And they are called the major modifiable risk factors and are considered to represent approximately 75% of the attributed fraction or the cause, let's say, of cardiovascular diseases. However, it's very important to understand that in the last 30 years, even with different approaches in order to control these classic risk factors, for example, the advent of certain drugs such as statins or anti-aggregant agents, cardiovascular diseases continue to be epidemic. So this makes the cardiologists start to think about other potential causes or contributory factors to the development of these events. And indeed, Nieto, a cardiologist, by the end of the last century, in 1998, for the first time, let's say that he went back again to that renewed interest in the possibility that systemic infections could be also risk factors for cardiovascular disease. And indeed, nowadays, in these novel risk factors, inflammation plays a pivotal role among them, as represented by certain biomarkers. The most widely known is C-reactive protein, which is a biomarker related with systemic inflammation, and that we will see later on that is increased in periodontitis, and that, as we will see at the end of the lecture, it can be reduced throughout periodontal treatment. So there are some concepts that we need to keep in mind, and indeed, among the similarities between periodontitis and cardiovascular diseases, apart from the ones that we have just mentioned, there are some similarities regarding their etiopathogenesis. And indeed, both of them involve an immunologic response. Both of them involve some catabolic activity represented by matrix metalloproteinases and interleukins, cytokines, and so on, prostaglandins, and so on. Both of them contribute somehow to a prothrombosis state, and both of them are related also with lipid accumulation and what we could call dyslipemia. The main, at the end of the way, of the path, the pivotal role, as I said, and probably the aspect that connects or the link between both diseases is inflammation. And indeed, we should bear in mind that periodontal diseases are inflammatory diseases. Of course, they are a consequence of the plaque accumulation and the response to this bacteria by the host, but at the end is the body, the immune response, that the one that is responsible of the destruction of the periodontal tissues surrounding the teeth. And indeed, if we take a look at the classic etiopathogenic model of periodontal diseases as proposed by Roy Page and Glenn Corman in 1997, microbial challenge is indeed just one, what we could say or name, it's a necessary cause, but not a sufficient cause, because at the end is the host response, the host immune inflammatory response, the one that is going to lead to the destruction of the attachment around the teeth and also to bone resorption, which are the clinical signs of the disease. But this host response is going to be influenced at the same time by some risk determinants that are not modifiable, genetics, and indeed we know that there's a component of genetics behind both cardiovascular diseases and periodontitis, but also there's an important influence on the host response that is derived from the environmental and acquired risk factors that most of the times are modifiable. So what are the mechanisms by which periodontitis has been linked to cardiovascular diseases, and not just cardiovascular diseases, but systemic diseases in general? Well, there's a direct pathway that is related with the enter of the bacteria that are present in the subgingival niche throughout the ulcerated epithelium of the pocket to the bloodstream, and causing bacteremia and maybe distant colonization, and exerting, as P.D. Miller said already in the 19th century, some harmful effects in distant areas of the body. And also, there's an indirect pathway in which it's not the bacteria, but the local inflammatory response and the increase in the levels of certain inflammatory mediators, such as interleukins, cytokines, the ones that are going to be at the end correlated also with some low-grade state of chronic inflammation that is characteristic of periodontitis, and that could also contribute somehow to the development of the lesion that is behind the cardiovascular events, the atherosclerosis, and this way putting in perspective the connection, the link between these two diseases. Of course, for some of these systemic diseases that are connected or related with periodontitis, the relationship is bidirectional, as for example diabetes, and for others it's unidirectional. So we don't have evidence that cardiovascular diseases involve or affect in any manner the periodontal status of our patients, but the other way around, let's say, or at least this is the evidence that we have nowadays. And as I said, inflammation is behind periodontal diseases, but inflammation at the same time appears to play a pivotal role in the development of atherosclerosis. And these direct and indirect mechanisms that I have already mentioned for the linking between periodontitis and systemic diseases are applicable also, of course, to cardiovascular diseases in particular. Because, and indeed, I'm going to try to present some evidence for the direct pathway at the beginning and for the indirect pathway later on. If we talk about the direct pathway, this is one of the things that are did when I was, this is indeed my first research project, I would say, the first thing I did in the lab. This was a study that was carried out several years ago, in which we received from the Oviedo General Hospital samples of vessels from patients that received carotidectomy. And from these blood vessels, what we did is to retrieve the atheroma plaques and perform some PCR, as we do nowadays for the COVID, in order to identify the presence of certain periodontal pathogens. And Okay. I will share my screen again.
¿Se te oye?
Mira, yo ahora...
¿Tienes solo una ventana ahora?
Solo tengo una ventana. ¿Me escucháis?
You can go ahead, Dr. Montero.
¿Sí? ¿Se puede? ¿Volvemos otra vez o no?
Yes, please.
Okay.
You were in the biological plausibility.
Okay.
Thank you very much.
So I assume that you can see my presentation again. And as I was saying, I have already explained the biological plausibility. The next question is to evaluate if the relationship between periodontitis and cardiovascular disease is a true association, or if it's because there are some confounders due to the presence of common risk factors among these two conditions. As I said, this is something that has been studied by both the cardiologists, the cardio field, let's say, and periodontists, the periodontal world, in a series of systematic reviews and consensus papers derived from several workshops. Particularly, today I'm going to refer to the one derived from the workshop performed in 2013 between the European Federation of Periodontology and the American Academy of Periodontology, in which the systematic review that was used as a position paper in this workshop observed that all studies, with the exception of one study, reported positive association between periodontitis and incidence of cardiovascular disease events. As I said, most of these studies were retrospective in nature, as it's very difficult, if not impossible, from an ethic point of view, to carry out longitudinal studies in perio patients to evaluate if periodontitis is a risk factor for cardiovascular events and leave them without treatment for a long period of time. As you can imagine, no ethic committee in the world will nowadays accept a protocol like that. Other findings that were particularly interesting from my point of view and that were observed in this paper was the association between periodontitis and cardiovascular disease was stronger in young adults, and that there was even no association among those ones that were older than 65 years old. And probably this is due to the fact that these patients, traditional classic risk factor present a weight which is much higher than the one presented by periodontitis. But particularly in young subjects, the periodontitis could be one of these risk factors with a low weight, but somehow contributory way to the development of the atherosclerosis plaques. So the epidemiological evidence among these conditions determine that the risk for suffering a cardiovascular event in subjects with periodontitis is statistically significantly higher than in periodontally healthy patients, which is very important. And particularly, the risk was higher for stroke than for coronary heart disease, and was higher in males and in young adults. If we take a look at this study that I already presented to you, in which we evaluated the prevalence of periodontitis in Spain, we are working nowadays in a manuscript that we hope to be published soon, relating with the periodontal status as represented by the Community Periodontal Index with the SCORE index. The SCORE index, or function indeed, is a risk measurement or a risk tool that is used to determine the probability to die of a cardiovascular event in the next 10 years. And what we observe is that the odds ratio of the association between the Community Periodontal Index equal to 4, which is presence of periodontal pockets of at least or more than 6 millimeters, and the presence of a high score was almost 2. So the risk was double for those ones presented a worse periodontal condition to present high score, independently of several confounders such as age, sex, education level, occupation, smoking habit, or the net income. And particularly, this association was stronger again for men and was stronger for those ones with previous history of coronary heart disease. In this case, the association between Community Periodontal Index equal to 4 and a high score was almost 5. So very, very, very important association. And the last step is to evaluate if periodontal treatment could somehow have a positive effect, not just in oral health, but also in the prevention of cardiovascular disease events. And the truth is that we don't have direct evidence for the prevention of cardiovascular events, but we have some evidence for some surrogate measures, such as, for example, C-reactive protein. C-reactive protein, this biomarker of systemic inflammation that previously we were explaining that was increased in periodontitis and also related with the development of atherosclerosis plaques and an increased cardiovascular risk, is able to be reduced by periodontal treatment in periodontitis subjects with measures of approximately 0.5 milligrams per deciliter. So really interesting. And if we move to another surrogate measure, such as, for example, endothelial dysfunction, we need to take a look at this study that probably is the most important study published in dentistry in the last 20 years, which is the study published in the New England Journal of Medicine by Mauricio Tonetti and co-workers, evaluating how treatment of periodontitis could improve the endothelial function. And this is a randomized clinical trial in which 120 patients were assigned either to receive a supragingival scaling, that was the control group, or what they name intensive periodontal treatment, which means scaling and root planning in 2 different sessions in this particular case. And they evaluated endothelial function and several inflammatory biomarkers at different time points: 1 day after treatment, 7 days, 30, 60, and 6 months after treatment. And what they observed is that in the day after periodontal treatment was related with a deteriorated flow-mediated dilation, and at the same time, and I will show you later on, with an increase in the levels of C-reactive protein. Let's say that periodontal treatment created a situation of increased systemic inflammation temporarily, because the truth is that at the end, when we go to the 6 months evaluation, 6 months after therapy, there were significant benefits in the reduction of C-reactive protein and the improvement in the endothelial function in one assigned to the intensive treatment group. So we have seen also that periodontal therapy is able to somehow reduce some surrogate measures of cardiovascular disease, and therefore we can think that reduce the risk for future cardiovascular events. And we have seen also that there is an association between periodontitis and cardiovascular diseases, which is independent of other common risk factors. But the next step is, what can dentists and cardiologists do for the oral and systemic health of our patients? And this was the topic and the objective of a recent workshop that was carried out in Madrid, particularly in between the European Federation of Periodontology and the World Heart Federation. And as consequence of this workshop, there was a consensus report that was published in the Journal of Clinical Perio, but also there were a series of leaflets that were performed by the European Federation of Periodontology and also by the Spanish Society of Periodontology, establishing the guidelines and recommendations for patients, for the oral healthcare team, and for medical professionals regarding the association between periodontitis and cardiovascular diseases. Particularly in the recommendations for physicians and pharmacists, the idea was that doctors and physicians were also aware about the potential bad periodontal situation of patients presenting cardiovascular events, and asking these patients to receive regular periodontal checkups and eventually treatment in case they need some kind of therapy. And also, I would say that it's very important to involve the physicians in primary care centers to be aware of the systemic implications of periodontitis from this point of view. And this is completely in line with what has been done by the Spanish Society of Periodontology in what we could name the Alliance for Health, both periodontal and general, and to which most of the most important scientific societies in Spain, including the Spanish Society of Diabetes, the Spanish Society of Cardiology, or the Spanish Society of Primary Care Doctors, have been attached to this initiative. There are also, of course, some recommendations for patients, particularly for those ones that have experienced previously some cardiovascular event. And these guidelines, just to finish, are related with also the management of these shared and common risk factors between both conditions, and are these guidelines published in the website of the European Federation of Periodontology, and it's completely free to have access to them and to download them. Regarding treatment, what are the recommendations for the oral health team for those that have been received or have been suffered an acute myocardial infarction, for example, or a stroke. Okay, it's important to understand that periodontal treatment is completely safe in these patients. It's important to understand that the bleeding risk is low for most of the procedures that we carried out in the dental setting, including those related with periodontal treatment, even in patients that are receiving anticoagulants or antiplatelet medication, and that nowadays with the new anticoagulants, most of the times there's no need to interrupt this medication, but we can control the possible bleeding with local hemostatic measures. Of course, if there are patients that are still taking warfarin or this type of anticoagulants that particularly in Spain are still very common, we need to take a look at the INR to evaluate the risk of bleeding for certain surgeries in these patients and eventually to perform an interconsultation with the doctor of the patient. But it's very important to understand that periodontal treatment in these patients could be helpful even to reduce the risk for future cardiovascular events. As conclusions of my lecture, and answering to the three questions that we have presented at the beginning, periodontal diseases and atherosclerotic cardiovascular disease are pathologies with a high prevalence in the population, and both of them a high impact on the quality of life of our patients and in the economic health field. Both pathologies present a robust epidemiological association that is independent of the shared common risk factors. And eventually, treatment of periodontitis not only has a positive effect on the level of oral health, but may also improve the levels of systemic inflammation and certain markers of cardiovascular disease, such as the endothelial function, with the potential added benefit on the cardiovascular health of our patients. And with this, I finish my presentation. I thank you for your attention. I apologize for the technical problems that we have had. I hope that you have enjoyed the presentation, and we are open to try to answer to any question that you may have. I will stop sharing my screen.
Mm-hmm.
And we are back. I apologize, Dr. Carasol and Dr. Gómez Doblas, for the technical problems. I don't know what happened, but I was talking to you, but I didn't know that you were not listening to me. So I continued talking.
Yes, we think that there are problems derived from the direct events, and we can know. Okay, so thank you very much, Eduardo Montero, Dr. Eduardo Montero, for your excellent presentation. We are sorry again about the commonness of this clinical trouble, and I have to thank to Dr. Gómez Doblas and Dr. Montero for this excellent session. It has become clear through the course that taking care of the mouth takes care of the heart. And that is why the role of the dental team is so important in this regard. Finally, I would like to thanks again to SEPA, Dentite, the speakers, and all of you for participation in this course that we hope will be very useful for your professional practice. Thanks a lot, and Dr. Gómez Doblas, do you want to say something?
Thank you, Dr. Carasol. I would like to thank you for PEPA and Dentite, especially because I think this seminar or this group of speech is very relevant because we are not only in our specialty, we can see more of our specialty every day, and we can talk about the transversal situation of the patient. And in my opinion, the opportunity that another specialist comment about another analysis about relation with the cardiovascular disease probably is a very good target for the odontologist, but for the cardiologist too. Mm-hmm. And my congratulations for all of you and all the colleagues that work in this series of speech.
Mm-hmm. Thank you so much for you and for the Spanish Society of Cardiology, of course. Now, Ernesto de la Puente is going to close the course in the name of Dentite, who has patrocined this course. Okay, thank you, Ernesto.
Good evening, Dr. Gómez Doblas, Dr. Montero, and Dr. Carasol, and good evening to all the professionals who are with us today. First of all, sorry about those technical troubles. Fortunately, we were able to continue with Dr. Montero's presentation that was quite interesting. On behalf of Dente and myself, I would like to thank you for your excellent presentations today, as well as the other speakers' presentations in the previous sessions. And thanks also Dr. Carasol and Dr. Gómez Doblas for their work as scientific coordinators of this course. And thanks, of course, also to the Spanish Society of Periodontology, SEPA, for his collaboration in these conferences. During these 3 sessions, we have had a course of very high level. Through this session, the different speakers, cardiologists and periodontists, those both professionals have shown us the significant relationship between periodontal diseases and atherosclerotic cardiovascular diseases. We have seen how periodontitis is considered a cardiovascular risk factor, and therefore how important is the relationship between oral health and general health. This is something very important and very relevant for the general health of our patients. In fact, this is a matter of public health. I believe that now it's everyone's responsibility to transmit these kind of messages from health centers, I mean hospital, dental clinic, pharmacies, to transmit these messages to patients. In other words, how good oral health and gum care, together with the regular visits at the dental clinic, can help to reduce this cardiovascular risk. Through the oral hygiene, through the, controlling all the risk factors of cardiovascular disease, we can improve heart on oral health of our patients. In this sense, Dentate, in its mission to improve people's oral health, offers to the population products of the highest quality and with scientifically evidence for oral health care under brands such as Vitis, toothbrushes, toothpastes, mouthwashes with cetylpyridinium chloride, and Perioate with chlorhexidine and CPC, with the objective to prevent and to help to treat periodontal diseases. I also think it's interesting to remember that Vitis Gingival and Perioate sponsor the working group of the Spanish Society of Periodontology, SEPA, and the Spanish Society of Cardiology, which is the origin of this course. We would like to thank again all the speakers and all the people who have attended to these courses for their excellent work, on, of course, for the excellent presentation of all the speakers. And I want to reaffirm Dentate's commitment with training in oral health through Aula Dentate and with science through the research that is carried out by the Dentate Research Center. Thank you all again. Thank you very much. And we hope to see you in next Aula Dentate courses. Thank you very much. Good evening and bye-bye.
Bye-bye.
Bye-bye.